Hello and welcome to Common Part B Nephrology Rejections and Denials. My name is Mary Mucco. I am a member of the WPS Provider Outreach and Education team at WPS, and I will be your host today. I'm joined by my friend and teammate, Bailey Lawson, who will assist with some behind-the-scenes help. This webinar is for those people who are wishing to learn about the most common reasons for Specialty 39 or nephrology rejections and denials. That is for Part B claims only, just as we advertised. You might be wondering why we are hosting this webinar today and talking about the common rejections and denials as opposed to policy for nephrology or documentation for nephrology. This webinar really, just as our advertisement says, focuses on the data, those top reasons for rejections and denials. Well, the answer to that is because in their internet-only manual, CMS instructs all of the MACs, the Medicare Administrative Contractors, to provide this education in order to avoid these rejections and denials on future claims. So that's why we are hosting this Common Part B Rejections and Denials webinar today for nephrology specialty claims. I do need to go over a little bit of housekeeping. The presentation materials for today are available to download from our live events webpage, and that page address is in the chat. You can take time now to download it if you've not already done so. We will be recording this session, and barring technical issues, we will post the recording on our Encore Presentations webpage, where it will remain for about 60 to 90 days. The recording will also post to our YouTube channel, where it will remain as long as the information remains current or until we otherwise decide to remove it. Now, if you have questions, please place them into the chat. I will answer questions as time permits. But if I don't get to your question, I will email the response following today's webinar. And I'll do so either directly to the individual that asked the question or placed it into the chat, or I will compile a list of questions and answers and share them with everyone that's participating in today's live event. If you have a claim-specific question about a rejection or denial, I am unable to provide an answer. And the reason for this is because staff in Provider Outreach and Education does not have access to any system information, any claim information. We can't look at claim history, for example. But you can get an answer to a question if you contact customer service. Someone in that department can actually access claim history, and they'll be able to help you with your question. Here is a disclaimer that we include in all our live events, and we do so to let you know that the information today is educational purposes only. I made every effort to verify that the information that I'm about to provide is current and accurate, but it is subject to change. It is on the CMS website where you will find the Medicare rules that determine final Medicare coverage. Laws, regulations, and rulings will always prevail. CMS prohibits recording of this webinar for profit-making purposes, and we ask that you do not record this presentation. We will create an encore of the presentation, and you can use that to access for future reference. Here is a copyright notice based on the American Medical Association's notice for CPT codes, descriptions, and other data, and I've included this CPT copyright notice in my presentation materials. Your continued participation in this presentation does infer that you agree to the terms of this copyright notice. Here is the agenda for today's webinar. This is exactly what the advertisement stated. Today, my goal is to share with you the most common rejections and denials for Specialty 39 or nephrology Part B claim submissions to WPS. Now, this is not a deep dive into policy. It's not about coverage, but it is a look at the most common reasons for Specialty 39 rejections and denials, and this is based on actual claims data. I'll define rejections and denials, reveal the reasons for rejections and denials based on the data that I pulled and analyzed, and I'll discuss ways to fix and avoid these and provide you with many, many resources. Now, this is a lot of information to share in 60 minutes. I'll be moving through the information very quickly. I may ask you to review some of the slides or some of the information following the live presentation. Most of that I don't plan to go over in detail and provide you only with listings are those resources, those helpful resources. They're located at the end of my presentation. Now, if you have questions, I'll tell you later how you can send them in. During the live webinar, though, you can use the chat, but following the webinar itself for a period of 7 days, you'll be able to send questions to me. Now, I can't begin to talk about rejections and denials without first providing a bit of information about the claim process. What I'm setting up here is a definition of rejections and denials. Now, based on a law that requires it, most providers do submit electronic claims to Medicare. When submitting electronic claims to Medicare, there are reports that generate that will confirm the claim receipt at WPS, and they often report more specific information about data requirements for claims. Now, one of these reports is the 276-277 report. The Medicare 276-277 companion guide, and you'll notice that I've embedded a link to that here on this slide, was prepared by our Electronic Data Interchange, or EDI staff, to help submitters understand the claim requirements and know when they need to correct or resubmit the claim. These edits when claims come into WPS are called pre-pass edits. Claims that move past those pre-pass edits, those that are actually accepted into the claims processing system by WPS, are going to generate a remittance advice. Sometimes people call this the notice, other people will just refer it as the RA, some people will just simply call it a remit. There are two formats, the electronic remittance advice, or the ERA, and the standard paper remittance, or the SPR. Now, with few exceptions, most providers are going to receive that electronic remittance advice. The remittance advice is very, very important because it provides details about the claim to the provider. So for adjudicated claims, you can find a lot of information on that RA about adjustments made, denials, missing items, refunds, and sometimes even offset information. When you're looking at a remittance advice, you will find various reason and remark codes. Now, these are typically in an alphanumeric format. When claims pay differently than billed, a claim adjustment reason code appears on that remittance advice, and sometimes a remittance advice remark code also appears. These expand on the details that are described by the reason codes in order to provide more details about the adjustment made to the claim. Another type of code on the remittance advice is called a group code, and group codes assign financial liability for any unpaid balance on the claim. A CO group code, for example, stands for contractual obligation, and what this means is that the provider is liable and can't bill their patient. A PR, on the other hand, PR group code that is, means that the patient is financially responsible. WPS hears a lot of comments about these codes, reason and remark codes. Providers talking with some of our customer service representatives will often state that these codes are too cryptic or that they contain outdated acronyms. While we'd like to help, it is another contractor, not WPS, that maintains these codes for CMS. You can find a link to the code lists on the Washington Publishing Company's website. It is on the WPC's website, where you can find contact information should you wish to suggest a change to some of those those reason and remark codes, including their explanations. I've inserted this slide to show you at a glance the difference between a rejection and a denial. It's very important that you understand there is a difference. A lot of people use these words interchangeably, and they really should not do that. Let's talk about rejections first. Look at the left side of this slide, please. A rejection is unprocessable. That's what CMS calls it. It's unprocessable. We can't process it. It's returned on what we like to call the front end. The reason why it's returned and unprocessable or rejected is because it's illogical. Something's missing. Something's not correct. There's incorrect information. Because that claim is never adjudicated, there are no appeal rights. what you need to do is resubmit the service. Fix it, resubmit it. When you see an MA130 and a CO16 code on that remittance notice, or the remittance advice rather, it should be a flag in the air right away that says you need to fix and resubmit it because it's a rejected claim. Because it's a rejected claim and not adjudicated, the patient is not liable. You can't bill your patient for something that you need to fix and resubmit. A denial, on the other hand, is actually adjudicated. Now, Medicare may deny claims for a number of reasons. I've placed some examples here on this slide. Sometimes an item or service that's submitted to Medicare is excluded from payment by law. We call these statutory requirements. Sometimes we can't allow payment for an item or service because it doesn't meet Medicare's medical necessity guidelines. And this would include any utilization guidelines or frequency parameters. Those are all kinds of medical necessity denials, or edits, if you will. Eligibility is another reason why claims are I almost said it. It's denied. Claims are denied by Medicare. Sometimes it's that the patient is not eligible on the date of service, but it could also be that the provider was not eligible on that date of service. When you see an MA01 code on a remittance advice, that means you have the right to an appeal. Now, with very, very few exceptions, when an item or service is denied by Medicare, you do have the right to an appeal, but there's always a couple of exceptions. I'm going to talk about one later. For denied services, the patient liability is determined. During the next slides, I'm going to discuss whether you'll need to correct or appeal a claim. Now, after reviewing the remittance advice, you're going to need to choose your action. For an unprocessable claim, one that was rejected, you need to fix the error and resubmit that claim to Medicare. If the claim or the claim line denied, there may be multiple actions to choose from. You may be able to simply resubmit the service after fixing it. You might use the clerical error reopening process to fix a clerical error, and CMS defines a clerical error as human or mechanical errors on the part of the provider or the contractor. Another action to consider is an appeal. The remittance advice, as I mentioned, will provide appeal rights with few exceptions. I'll discuss appeals just a little bit later in this webinar. Now, registered users of the SecureNet Access Portal, we call that SNAP. That is the transactional side of our portal. It is a secure site. You can use that self-service tool to request a clerical error reopening. You can actually facilitate the reopening yourself and make that claim move on to payment if payment is allowed. Or you can request an appeal using SNAP. Now, this is a self-service tool, as I mentioned, and all of the self-service tools developed by the Medicare Administrative Contractors, or the MACs, really do offer the most efficiencies. And we do have a portal user manual that provides illustrations and step-by-step instructions on how to use these portal features. I do want to show you on our website where you can find that portal user manual. And remember that it offers illustrations and instructions on how to render the various functionalities of our SecureNet Access Portal. This is the home page of the WPS website. Near the top in this blue box where you can log into the portal, right here off on the right side is a link to the portal user manual. If you scroll to the bottom of any WPS web page, you'll see this great big blue box on the bottom. It has a lot of great information, including how you can click on this Facebook icon in order to connect to or to start following our provider Facebook page. That is just an extra educational opportunity for you. But right here in the middle are other educational opportunities, and one of them is a link to the portal user manual. Illustrations, step-by-step instructions on how to use it are available. I do want to talk about appeals really quickly before I move into the data portion of this presentation today. For claim denials, most often you can request an appeal, and the purpose of the appeals process is to ensure the correct adjudication of claims. Physicians, suppliers, and beneficiaries have the right to appeal claim determinations that are made by MACs. The beneficiary or the representative may request an appeal on any service that's processed for them. This would include both assigned or non-assigned claims. However, providers and suppliers may appeal services for which they accepted assignment. For unassigned claims, though, providers and suppliers can act as the beneficiary's representative, but the beneficiary would need to sign an authorization statement for them to do so. Additionally, a provider or supplier can request an appeal or a redetermination on an unassigned claim, but only if Medicare denied that service as not reasonable and necessary, or in those situations where the provider or supplier billed in excess of the limiting charge. And of course, anytime a provider does that, they would need to refund any fees collected from the beneficiary or overpayments from the beneficiary. Now, there are 5 levels of appeal. There is only one level of appeal that is rendered at the max. So WPS renders only level 1 appeals. Those level 1 appeals are called redeterminations. All 5 levels have time limits to file the request. There's also time limits for completion that apply. So for example, you may have 180 days to file a redetermination appeal request, but we have only 60 days to get that reply back to you telling you whether we have reversed our initial determination. I want to show you a couple of helpful resources while we're talking about appeals. One of them is, and it's the first bullet that I've embedded a link to here, how to appeal a claim determination. If you look at this on our website, it provides you with instructions, information about all those 5 levels of appeal. And I do need to move back just for one moment because I neglected to tell you that there are some amounts in controversy that apply to 2 levels of appeal. Level 3, which is the ALJ hearing, administrative law judge, and level 5, which is federal court review. You need to meet a minimum dollar amount or a threshold amount in order to be able to submit that level of appeal. But you can combine similarly rejected claims in order to reach that dollar threshold. Now, back to the resources here. I talked about the resource on our website that's called How to Appeal a Claim Determination. Tells you where to submit it, how to submit it, provides information about submitting it using self-service tools such as SecureNet Access Portal. But one of my absolute favorite resources that applies for appeals is one that's called the CMS Fee-for-Service Appeals Process Flowchart. And I've included a graphic in your handout for you to remind you of what it looked like, but I'm going to open it up to speak from the website itself. It should be opening here, and it's opening on my other monitor, so I will pull it over right now so that you're able to see it. I'll make it a little larger. This is one of my favorite CMS publications or resources. I like it because it describes the original Medicare, both Parts A and B, fee-for-service, appeals process. Okay, there is the standard process that applies to Parts A and B. My webinar today focuses only on B information, so we're going to follow this left side. The expedite process for appeals that applies to some Part A claims is on the right, but I'm not going to be talking about that today because we're going to stick with Part B, just as I advertised. Here shows the initial determination. This is when WPS processes your claim. You have 120 days to file the first level of appeal, which is called the redetermination, the only level of appeal done at the MAC. We have 60 days to make our decision and send you notification of such. Now, if you're not satisfied with the outcome, you have 180 days to file the second level of appeal, which is the reconsideration. It's done by another contractor, not WPS. That contractor is the Qualified Independent Contractor, or the QUIC. They have 60 days to render their decision. Now, as you can see, following along with this flow chart, the third level of appeal is here, which is the Office of Medicare Hearings and Appeals, fourth level, Medicare Appeals Council, and the fifth and final level of appeal, which is judicial review. All of these show those time frames that I talked about. How long do you have to request that level of appeal? How long does that contractor have to provide you with a notification of the outcome? Now, remember I talked about those amounts in controversy, those dollar thresholds? The dollar thresholds, or the AICs, the amounts in controversy, apply only to level 3 and level 5, and they are right here on the flow chart. AIC is greater than or equal to $190 for the third level of appeal, and the AIC is greater than or equal to $1,900 for federal district court. And remember, you can combine claims in order to reach that threshold. What I want to point out when you're using this resource on the CMS site, and I embedded that link, is make certain that you're paying attention to the date. This chart reflects the amounts for calendar year 2025. Those amounts in controversy can and often do change each calendar year. So, you know, when we get to late December and you're pulling this up, or even into January of 2026, you're going to want to make sure that the information on that flow chart is updated. So you'll be looking at the amounts for calendar year 2026 when that comes along. It's just around the corner. Boy, this year is going by so very quickly. Back to the PowerPoint, and brings us now to the information that this webinar focuses on, that being the data. I used a tool that we call the Claims Data Dashboard in order to pull the data that I'm about to share with you. The dashboard is an interactive tool. It's designed by our data analysts in our data department, known at WPS as Insight. Insight is the name of the unit that is responsible for mining data, creating these tools, and I'm going to show it to you in just a moment, looking at data trends, assisting other departments, among other tasks and responsibilities. There's different ways that we can view data using this tool that I'm going to show you. And I'm going to show it to you right now here. Make it a little bigger so it's easier to see. This is the data dashboard that I use to analyze data for today's presentation. I'm going to make it just a little bit smaller. This is the tool developed for people like Bailey and me in provider outreach and education to take a look at data to determine whether we need, or there is a need, to provide education. Just as CMS instructs in their internet-only manual. Now, there's different ways for us to view this data. We can, in an instant, look at rejections versus denials. I could change this data slicer, as they call it. There's denials, there's rejections, and see how quickly that changes. I can also drill down by state by adding a particular state here. I can look at all states, of course. I can look at Part A data or Part B data, and today I'm looking at B. I can look at Jurisdiction 5, Jurisdiction 8. Today I'm looking at both jurisdictions. So as you can see, we can very quickly, just in a click of my mouse, look at this data and see the top denial reasons, the top codes that were denied by WPS, and not only that, it has the number of claims, okay, denied. So I'm looking at denials now versus rejections. So we're going to talk about each of those in just a moment. But today, just as advertised, this particular webinar is for Specialty 39 providers. So I'm going to add Specialty 39 to my data slicer, as they call it, in Insight, and you can see how those numbers have changed. Okay, if we take away the Specialty 39 and look at all specialties, these numbers get a lot larger. But today we're just focusing on Specialty 39 claims. It's my thought that if we provide you with the most common reasons for rejections and denials for your specialty, that you'll be able to avoid those in the future, and these numbers are going to be a lot smaller, okay? Hopefully we can eliminate them altogether, because we want to pay you for those services you're eligible to receive. We want you to receive payment, correct payment the first time. We don't want you to have to resubmit a claim, and we don't want you to have to appeal a claim. We want to pay you for the services that you're entitled to be paid for. All right, let's go back to the PowerPoint. These this just reflects what I mined or what I analyzed today. Jurisdiction 5 and 8 nephrology claims submission dates were April 1 of 2025 through June 30 of 2025. If you look at that tool that I just showed you, you'll see that the data that our analysts pull is in 3-month increments. So in this case, when I pulled everything together to create this presentation, get these presentation materials out onto the website, it was submission dates April through June. Last refreshed on July 14th. So every month, around the middle of the month, our data analysts will take 1 month away and add 1 month on, and then they'll provide for us the data that they last refreshed it. Why is that important? It's important so that I can go out 6 months from now, look at the same information to see if there's any change based on that education that I provided. Okay? So that's a way we can monitor and tell CMS that there is an impact based on the information we provide in our education. So here then is a look at those common rejection reasons. Rejections first, we're talking about for your specialty. I've included the number of those rejections. That's the same thing as claim lines. Specialty 39, 807 claim lines were rejected in that 3-month period because there was an incomplete or invalid plan information for other insurance. This means that you told us there's other insurance, but you didn't give us the information that the claim requires about that other insurance. CMS publishes claim form instructions. It says, what do you need in item 1? What do you need in item 2? What do you need in item 3? Is it required or situational? Do you have to put it on every single claim? But there are those claim form instructions. I've included both the paper claim form instructions and the electronic claim form instructions on that big long list of resources at the end of today's presentation. I do want to show you one of the tools that will help you submit claims correctly. I'm opening it up here on my other monitor and opening it. And I've included an embedded link to this resource. I'm going to show you. Some of us are searchers, some of us are navigators. If you're working and you want to find this tool quickly, I'll show you how you can navigate to it. If you are on the WPS website, go to Quick Links, you will find EDI, which stands for Electronic Data Interchange. When you click on that link, you'll notice that you have left WPS's website. You are now on our EDI webpage. Scroll down, click on Medicare EDI. We also have commercial insurance and we have TRICARE contract. Here are those companion guides I talked about earlier that you look at when that 276 and 277 report when you're submitting claims to get them into the house, those pre-pass edits. But what I want to talk about right now is this crosswalk, CMS 1500 to 837 crosswalk. Remember that rejected claims are illogical, they're missing something, something's not entered correctly. This is a tool that I like to show providers because many of you have never seen that or know that this exists. And this crosswalks from a paper claim form, which is a CMS 1500, to the current electronic version claim, which is the 837-5010. So as you move through this crosswalk, you'll notice at the left side of the page, if you read the top column, it says item number. That stands for the item number on a paper claim. Narrative tells you what it is that goes there. The data element description explains on the electronic claim what you're placing in there. There's also requirements for the electronic claim form listed over in the far right column. Remember I just said some of the items on a claim are required every time, some are situational. Well, how do you know which items are required and which items aren't required? Take a look at item 21, for example. You'll see that the principal diagnosis code is R. It has an R status. R means it's a data element that's required to process the claim. If it's not there, what happens? Your claim is going to reject. You'll notice additional diagnosis codes listed here in item 21 on the claim form, and here's the electronic equivalent. Here shows you the loop and this area of the claim, the electronic claim that you need to populate. If you have multiple diagnosis codes, it's situational. It means it's a data element that must be completed, but only if other conditions exist. So in other words, you have to have at least one on your claim, but you can have more, okay? And this provides you with the requirements. That's the crosswalk. If it goes in item 32 on the paper claim, where do you put it on that electronic format? It's a great tool, and I like to show that one to people that are attending this event, because if something's missing, it's rejected, okay? For example, facility lab name and address or PIN is missing from your claim. This is the second most common reason why we rejected claims for Specialty 39, nephrology, in that 3-month period. Rendering physician number invalid or missing. 324 claim lines in 3 months. Put a dollar amount on each one of those claims. Every single time you have to fix it, resubmit it, it costs you money. Every time that we have to bring that claim into the house and reject it and send you that notification, it costs Medicare money. So we're looking at this as a cost savings. A lot of these are self-explanatory, so I'm not going into a lot of detail. Let's look at the 4th most common reason Specialty 39 claims are rejected. That claim must be submitted to the Railroad Board. Railroad Board Retirement is a Medicare administrative contractor, specialty contractor, who processes claims for all Medicare beneficiaries who have retired from the railroad. How do you know if someone retired from the railroad and they're eligible for Medicare through Railroad Retirement Board? You look at their Medicare card, and at the very bottom, there's a banner at the bottom. If they are a railroad retiree, it will say Railroad Retirement Board. You need to send that claim to the railroad specialty contractor, which is Palmetto GBA, not WPS. Okay. Another way to check that would be, or to recognize where a claim needs to be submitted, of course, would be to check eligibility. And there's self-service tools for eligibility that you can use to do that. The next most common reason for rejection is that the place of service conflicts with the procedure code. Certain procedures can't be done in certain places of service. Think of a cardiac procedure, a complex cardiac procedure. Now, are you going to do that in an office? Probably not. So if you have place of service 11, which means office, with that CPT code for that complex cardiac procedure, the claims processing system is going to know, because of the edits built into our system, that that place of service code doesn't go with that procedure code. So you need to fix it, resubmit it. Was your place of service reported properly? Did you choose and report the correct procedure code? Look at the next one. Missing, incomplete, invalid ordering primary provider or primary identifier. 68 claims. There are certain services that require an ordering or referring provider, and CMS has on their website a great tool. It's an ordering and referring provider file where you can search by name to get the name of an ordering or referring provider along with their national provider identifier, both of which you need to enter that NPI on the claim. So if your claim is rejecting for this, make sure you entered it correctly. Is it where it needs to be on the claim? Is that ordering person or referring provider, this one says ordering only, is that ordering primary identifier correct? And is that individual actually eligible to order that service? I'll show you a tool later that you can look that up. Missing procedure modifier 49. I want to show you on our website some tools to avoid this. And here is the website again. I'm a searcher, not a navigator. There is no right way or wrong way. It's up to you. I'm going to type in modifier. You'll see it's remembering some of the pages I've visited. But here is a result for modifiers. And you'll see on our modifier webpage, and I've included this in your resources, there are embedded links to all of these pages on our website, these fact sheets. Let's look at one. Modifier 25 fact sheet. This is just an example. All of our fact sheets that we have for modifiers include a definition. They include appropriate use. They include inappropriate use. Sometimes there's additional information that we add. In this case, we've added some statements that are false when considering use of this modifier. And many times we'll include a list of the eligible procedure codes that go along with the 25 modifier. So what that means is if you report a 25 modifier on a claim for anything other than these codes, it's going to reject. Okay? Fix it, resubmit it. All right, let's take a look at a few more reasons for rejections. Patient, insured, HIC, and name do not match. What this means is that the Health insurance claim number reported on the claim, which is now a Medicare beneficiary identifier. Remember earlier I said some of these reasons that code print out include outdated acronyms. Well, that is, and I know it, but I wanted to place this on the slide just as it actually reads when you get that information. When we mine this data. So this means that the health insurance claim number and the name do not match. Make certain you're taking a look at that Medicare beneficiary's card. Report the Medicare beneficiary identifier correctly. Make certain it was keyed correctly. If the Medicare card has the patient's name with a middle initial, I always like to use my middle initial. My mom's name was the same. So for many years, our first name and last name was the same. And then my brother married a Mary also. So we had, you know, 3 Marys with the same last name. I like to use my middle initial, and often when I'm filling out important paperwork and such, my middle initial, which is E, is there. Well, if my Medicare card someday shows Mary E. Muko on it, then I need to make certain that, or the providers would need to make certain that that E is also on my Medicare claim. Next one, claim must be submitted to the United Mine Workers of America. This is kind of like that Railroad Board retirement, in that United Mine Workers of America's health and retirement funds has a special arrangement with Medicare for coverage of retired miners. The funds, that program or funds, health and retirement fund, is the primary payer for Medicare Part B services if you have no other group health plan that is primary. So in this case, those 28 claims shouldn't have come to WPS. They should have been submitted to United Mine Workers of America Health and Retirement Fund. Next, invalid or missing modifier. I showed you those modifier sheets. And next, field 11 of the HCFA 1500. We know it's not called that anymore. That's how it reports, how it prints out when I mined the data, when I looked at the data reports. It's the CMS 1500. But field 11 has to be filled out. And if the answer to the question, is there other insurance primary to Medicare, is no, you can't leave that box blank. You have to put something in there. So you should write none. Okay. So I thought it would be interesting to show you not just the reasons why something denies, but the codes. Let's take a look at those codes now. All right. The 99232 is the subsequent inpatient or observation care visit that involves moderate medical decision making. Incomplete, invalid plan information. We talked about that. We talked about place of service conflicts with procedure code. We also talked about the next one, facility, lab name, and address or PIN missing. 99214, very, very similar. The only difference here is that the claim must be submitted to Railroad Retirement Board. This, folks, is the reason why we're rejecting your claims. These are the reasons, okay? If we avoid these in the future, then the claims won't be rejecting. G2211 is that E&M visit complexity code when there is a long-term relationship with the patient, that longitudinal care. Why are we rejecting those claims? Same reasons. Okay. 99233 is the subsequent inpatient or observation care visit, but it allows or involves E&M high-level medical decision making. Very, very similar, these reasons. If these are codes that you are submitting to Medicare, make certain that you avoid these errors. Okay. 90960, this is the ESRD or end-stage renal disease related services monthly for enrollees 20 years of age or older with 4 or more face-to-face visits by the physician or qualified non-physician practitioner per month. These are the reasons why we're rejecting those claims. Nothing new here. 99223 is the initial hospital care, 75 minutes or with high medical decision making. Same thing, nothing new is popping up here. These are the reasons why those codes are rejecting based on the data that I analyzed. I mentioned to you that we can look at trending. I'm going to show you that real quick. I'm going to pull this open over on this side. Hang on, bear with me just a moment. I have to get it ready. Make sure that I have all the information you need to understand. One of the things that we can look at using this tool that I showed you earlier is trending denials. So right here I'm looking at trending denials instead of searching for denials. I'm looking at trends. You can see that our trending shows that for denied Part B claims, oops, it shows 47. We want 39. Nephrology. It remembers what you last looked at when you're using this tool. So when I last looked at trending, I looked at specialty 47. 10,899 claims the prior 3 months, but 15,000 the current 3 months. That means claims are up. This shows you the denial code descriptions right here in this middle column. Shows you the claim count for the current 3 months, the prior 3 months, the difference in claims, and the claim percentage change, and then we see these arrows up or down. We want to see the red arrows showing down. We want decreases in all of these denials, okay? So I just pulled out as an example, and in my presentation for you, one example. Rendering physician number invalid or missing. We're talking rejections here, not denials, like I just showed you. Current 3 months, there was 324 claims. The prior 3 months, 93. The difference is 218. That's an 82% increase in rendering physician number was invalid or missing for your specialty during that 3-month time period. This, folks, is why I am providing this education, just to alert people to these rejections and denials and to avoid them in the future. Now let's talk denials. We talked about rejections. We know that denials are very different. Why are specialty 39 nephrology claims submitted to Part B Medicare, WPS, being denied? The number one reason is that collection of fee-for-service during periods of managed care, 2,735 claim lines denied. What that means, and I know that this one is one of those rather cryptic ones. I actually went to our system staff and said, what does this really mean? Does it mean that the patient has Medicare Part C? And the answer I got was yes. That means that this beneficiary has a managed care plan. The services that needed to be denied was 2,735 claim lines. Look at the next one, duplicate charge, 922. Look at the fourth bullet, duplicate charge paid on such and such a day on claim number XYZ, or the ICN would follow, 859. Remember when I talked earlier about dollars? Add 922 to 859. Put a dollar amount on each one of those. That is money that is being spent when we deny duplicate claims. Duplicate, duplicate, duplicate. Happens all the time. Every day we deny thousands of claims that are duplicates. There are ways you can avoid duplicate. We have a resource on our website. Sometimes you can add a modifier, and that tells us, or the system logic will see, this is a repeat service by the same provider. This is a repeat service by another provider. That avoids that duplicate denial. So consider modifiers. If you use a billing service or within your organization, you automatically just rebill every 30 days without doing your due diligence and checking to make sure that that claim, or checking that claim status, stop doing that. It is considered abusive. It is representing an unnecessary cost to the Medicare program. It costs the Medicare program money, but it also costs your organization money to prepare and submit that duplicate claim. So we need to avoid those denials. Expenses incurred after coverage terminated. Okay, the beneficiary coverage has terminated. Maybe they're no longer eligible based on the end-stage renal disease Medicare benefits. 871 denials. This one you'd want to check eligibility to avoid. The final one here is that the claim must be sent to the employer group health plan first. That means another insurance is primary to Medicare. 596 denied claims. That too would be one where you'd need to check eligibility. Not covered when performed, referred, or ordered by this provider. Remember I mentioned that referring and ordering list of providers that CMS has available on their website. I'm going to give you that link in the resources at the end of my presentation, check to make sure that that provider is eligible to order or refer. Check to make sure that you entered their number correctly. If you need to, you may need to make a phone call to find out who was the ordering or referring provider or performing for this particular service that you're billing. Expenses incurred prior to coverage, 531, that's an eligibility issue. Claim must be sent to the EGHP, Employer Group Health Plan, or the large group health plan first. That's a Medicare secondary payer denial, and that is one also that you would need to make certain that you're checking eligibility each time to make sure that something hasn't changed with the coverage, that someone else isn't responsible for payment of that claim versus Medicare. That's an eligibility check. And finally, Medicare's secondary payer, send your claim to the primary insurer. There's many different ways and reasons why we would reject a claim or a claim line for Medicare's secondary payer. So you will see that sometimes, even though it's for the same reason, the reason code that prints out on your remit is going to be different, okay? So it's just something to keep in mind. I noticed that a lot of you, and I sent an email out because of this, when submitting or when registering for today, a lot of you wanted information that deals with policy, coverage for ESRD services. A lot of you were looking to find or were hoping to have your questions answered about documentation, but that's really not what we advertise that this education webinar is about. That's not to say we can't provide that in the future, but as you'll see, it's 10:47 now. I have 60 minutes dedicated to rejections and denials, but we do want to hear from you. We want to know what you want to learn about. I know that you submitted these and I placed them into our, we have a list of suggested topics for future education, but after today's webinar, you'll receive an opportunity to complete a brief survey. And in that survey, you can give us your wish list. So if you can think of anything else or something specific that relates to nephrology or end-stage renal disease, let us know and we'll do our very best to make that happen. All right, let's look at the codes and all of these codes and reasons that I'm giving you today. I neglected to tell you earlier, it goes from the most to the least. And of course, I don't include all of them because as you saw when I opened up that tool, there's just numerous reasons for rejections and denials. If you think you want to hear more about other rejections and denials, we can have another webinar. That's something you'd want to put on that that brief survey that you're going to fill out. 99232 and 99233, I put them together on this slide because they were the #1 and #2 denied codes for your specialty. And here are the reasons. These are all reasons that I already talked about. 99232 is that subsequent inpatient or observation care visit, E&M, moderate medical decision making, and 99233 was the same high medical decision making. Okay, so keep in mind that these do go in order, and the reasons why those two codes denied, the top two codes that denied for your specialty, look at them. They're E&M codes. They're not dialysis codes. I thought that was interesting. That these are the reasons why they're denying. 90960 is dialysis management for home dialysis patients, and here are the reasons why these are denying. Fee-for-service during managed care, billed, denied. Expenses occurred after coverage terminated. You have to keep track of those dates. Eligibility for end-stage renal disease patients. Not covered when performed, referred, or ordered by this provider. And look at that next one. The time limit for filing your claim has expired. This has been popping up a lot lately in that we're getting a claim and you have 1 year from the date of service to submit a claim for processing. If you don't do that, we will deny your claim that the time limit has expired, and there's no appeal right. That, folks, is one of those exceptions I talked about earlier. When I mentioned your claim will have this code on it to tell you you have an appeal right or a right to an appeal. When we deny a service that the time limit has expired, there is no appeal right. Okay. You can only charge the beneficiary 20% of what you would have been, or what would have been the approved amount by Medicare. If that happens, you can file a waiver and tell us why we should reopen your claim and waive the timely filing. We do have an article on our website, and I want to show this to you because this one keeps popping up in all kinds of specialties. Let's make that a little bigger here. Timely filing. This tells you about submitting that timely filing of claims. This is included in your resources at the end of your presentation materials. This tells you about timely filing, the restrictions, why we might extend that date or that late filing. It tells you where you need to submit it. So this is the J8 website I'm on now because it shows Michigan, Indiana. Another way to know what website I'm on is to look at this banner at the top of the page. If you need J5 Part B information, you click on it, and it now shows Iowa, Kansas, Missouri, Nebraska addresses. This tells you where you need to submit your good cause statement to our claims manager in order to request a waiver of timely filing. What I want to point out is this, folks, and we put it right in this resource. CMS says, not WPS says, WPS says because CMS says that we cannot reopen a denied claim for timely filing when the reason for that late filing is because another insurance recouped their previous payment and caused the delay in filing to Medicare. Happens all the time. We get a lot of questions about it, but CMS says third-party payer error in making a primary payment determination does not constitute good cause for the purposes of reopening that initial determination or redetermination. So just something to keep in mind. I mentioned to you that we use these numbers when planning education. This keeps popping up, time limit for filing, and not just your specialty, but other specialties. So one of my colleagues has recently held not just one, but repeated webinars on timely filing. This helps us know what we need to educate on. 99214, of course, is another E&M code. There are the reasons. Sorry about that. Getting a little click happy with my mouse. 90970. That is less than a month of dialysis management for home dialysis. There are your reasons. It has nothing to do with policy. Nothing to do with medical necessity. These are the top reasons that code is denying. G2211 is that visit complexity code. The reason why we're denying that is that patient had managed care, Part C, duplicate, and then the other is that the service is not payable with other services rendered. This code can only be used with E&M codes and some prevent services. What happens when it is billed with a code that it's not eligible to be billed with? We deny it. So that's the reason why we're denying that complexity code. All right, 90935 is hemodialysis subject to global surgery guidelines. This is, there are the reasons for you. Expenses incurred after coverage terminated, dupe, and patient has Part C. Here is a trending example. I chose timely filing, 614 claims denied, or claim lines denied the current 3 months, only 378 the prior 3 months. There's the difference in the increase. Why do we choose topics to educate about? This helps you understand that, I believe. So then what I've done here is placed how to fix things. And I know that I've talked about a lot of this as I've walked through the reasons for rejections and denials. Typically when you see fixes, that means rejection. So here's what you need to fix: rejected claims for modifier issues. I've talked about these. Make sure it's there if the claim requires it. Make sure that modifier goes with that CPT code. Make sure that modifier was valid when you build it. Eligibility fixes, we had a lot of those today. Railroad Retirement Board, we had Part C issues. We also had those claims that should have been submitted to United Mine Workers of America's Health and Retirement Fund. CMS has on their website a map that you can click on. It's an interactive map, and it will tell you who the contractors are for that particular state. That's included in your resources. Provider number fixes, make sure you're keying them correctly. You might need to contact provider enrollment to make certain that the enrollment records are valid or up to date. Make sure provider ordering information was entered on a claim when it requires it. Duplicates, I've already talked about that. We have a resource on our website that gives you tips, more than what I've given here to avoid those denials. Make sure you're adding a modifier if it will alleviate the denial. Don't auto resubmit that on a 30-day cycle without establishing status for the claim. We had MSP issues pop up. Here is a bunch of resources available to you, including an MSP playlist on our YouTube channel. As I mentioned when we got started today, we are recording this this webinar, and we'll be posting it to our YouTube channel. So it will appear, this recording today will appear on our Rejections and Denials playlist. You can go out and look at other rejections and denials for other specialties if you are in a multi-specialty clinic and you're interested in that. More resources and tools. Here's the claims processing manuals, both electronic, paper claim, and then I've included some information about the EDI support requirements. IVR is a tool where you can find claim status and details. It's an self-service tool using your voice or telephone keypad. Here's a link to the operating guide. Similarly, we have the SNAP Secure Net Access Portal that's available 24 hours a day, 7 days a week, with limited functionality outside normal business hours. But this will help you check eligibility, claim status, claim details, and claim actions. And remember, we have that portal user manual with illustrations and step-by-steps to avoid them. This is an article on our website, How to Correct a Rejected Claim. I talked today about reason and remark codes. Look at your remit, look at the reasons why, or the remark codes, why your claim rejected. Come out here to this resource and it will show you those reason and remark codes and tell you this is what you need to do to fix it, okay? Similarly, we have the same thing for denials in this resource on our website, although we've kind of chunked these out by categories. So we have information about bundling. We have duplicate claim denial information. But look for those reason and remark codes that you're seeing on your remittance advice. Come out here to this article and this will say this is what you need to do. Here's our website. Here is a link to an article. I talked about clerical error reopenings. You can request one or do it yourself if you are a SNAP user, or you can call in and have this done for fixing those minor omissions. Here is a link to the modifiers webpage I showed you, a link to the timely filing article I showed you. Here is a link to our live events webpage, Future Education, Encore Presentations, where we place our recordings 60 to 90 days. Here's a place of service code list. So if you have claims that are rejecting or denying because the CPT code doesn't go with that place of service, here you can verify your place of service. And again, links to the YouTube channel for Medicare Advantage information, avoiding timely filing. EDI webpage, there's that link to that crosswalk. Remember, there's links to the companion guides. Here are other CMS resources. This one is about checking eligibility. Here's that link to that contractor directory, that interactive map. If you're from Michigan, click on Michigan. It tells you who's who does what. The physician fee service relative value files I've included, which has a status code column on it. If you see a B in the status code on the physician fee schedule relative value file, it means the service is bundled. Order and referring files, I talked about that a few times today. This is that searchable by name file that CMS has that says all of these providers are eligible to order and refer in the Medicare program. And it gives you the NPI, the National Provider Identifier. Here's some education on the G2211 because that popped up as one of the most common denials. We have hosted webinars in the past about this code. Recordings are available on our YouTube channel. You can also look in CMS's E&M Services Guide and on our webpage for information about G2211. And here, folks, is where I would normally open for live questions and answers, but we have run out of time. Typically, these webinars have been going just a couple minutes over, so I'm going to wrap this up really quickly. If you placed a question in the chat, I will definitely send you a response or get a response out with the answer to that. I'll tell you in a minute how you can send questions. I wanted to mention to you the importance of that survey that you heard me make mention of. This is where you can make suggestions for change. We're very, very proud in provider outreach and education to use those survey comments to effect change. We have added chapters to our YouTubes. That means you can move within we place in the description of one of our videos that at 2 minutes and 9 seconds you can talk about rejections, and at 4 minutes and 18 seconds we talk about denials. So you can move within that recording to what you're looking for with the information you need. You don't have to start it, stop it, and move forward. You can move right to a designated chapter, if you will. We've also added training indicators to all of the advertisements for our education events. You know, is it designed for compliance officers? Is it designed for coders? How about billers? Clinical staff, non-clinical staff, Part A, Part B, so on and so forth. So we've done that based on your wonderful suggestions that come in those surveys. Some of you today are joining us and you're looking to an organization or entity to give you continuing education units because you attended this for an hour today. Following this webinar, and it's actually running over, so you might have already received it, you're going to receive an automated thank you email from WebEx. And it's going to have in that email, not in an attachment, this verbiage over on the left. It'll say this certifies that you successfully completed today's event. It was an hour. It will give you the date. This, folks, that email is what you need to forward to the accrediting body so they will consider giving you CEUs. Now, if you are listening only today, you joined only by phone, you're not seeing what I'm showing in my slides, but you know, you have the handout so you're following along. Our WebEx platform, or WebEx does not have webinar platform is what I should say. WebEx doesn't have all of the information they need to send you that email because you joined by phone. So what you'll need to do is send an email to WPS's education mailbox. The email address is at the bottom left of this slide, and I'll show it to you. It's on the next slide, I believe. Tell us you need CEUs. Tell us the name of the event. And give us your telephone number, and we will look in the WebEx records for that telephone number, verify your participation, and send you an attachment to the email that says, here is your CEU, or that actually is your certificate of achievement. So join by phone, you're going to get an attachment. It's a certificate. If you join by not by phone, if you're actually watching what I'm showing here on the screen, you'll get an email, and it's in the body of the email. It's not a separate attachment for CEUs. Okay. Follow-up questions. Here's that education mailbox if you join by phone and you need CEUs. And also, if you have a question that comes up related to anything that I've talked about today, you have 7 days until noon, until noon the 7th day, to submit that question. In the subject line, if you would, put rejections and denials and nephrology, and the person in my unit that is monitoring the education mailbox will know to send that email to Mary Moko so she can get the answer out to you. Remember, I will respond directly to you, or I will create a list of questions and answers and send it to everyone participating today based on those records that I'll get from WebEx. I talked about the survey a couple of times. I am begging, yes, you heard me say beg. I am begging you, asking you, please complete this survey. It is so very important. We look at every single survey. We look at every single comment. We make changes based on what's in that survey. You know, if we get 3 surveys that say, we don't like this, change it, but we get 76 surveys that say, we really like this. Are we going to make the change? Probably not. But, you know, if it's a new innovative idea, something we can place into our education, or a process we can do to make things better for you, we want to do that. Send us your suggestions. Let me know how I did today. Let me know what you want to hear about in future webinars. You want that documentation webinar. You want a webinar about policy related to nephrology. I've already added those to the list, but you know, let us know in those surveys, because it's not just WPS looking at the survey, it is CMS also looking at the survey. Now, there is a link in the chat that Bailey's placed there, but we give you one last chance today You can always go back to the link that's in your handout too. We're giving you one last chance today. When you exit this webinar today, you're going to get a pop-up message. It's going to look like the box at the bottom middle of your screen with the yellow triangle at the top. This is just a message saying, hey, we're taking you to another website. And if you look at that destination site, it is CMS's Qualtrics or their survey website. It's not malicious or anything. If you've not yet completed the survey, go ahead and click on the blue button and complete that survey. We want to hear from you. On behalf of Bailey and myself and our entire provider outreach and education team, I do want to thank you for attending today. We look forward to your survey contacts. We thank you for your participation, and we hope to have you join us for future events. You may now disconnect. Thanks, everyone.